Welcome to The Explainer. Today we're diving deep into the essential rules for coding diseases of the respiratory system. We're going to be using Chapter 18 of the ICD-10-CM as our guide, and we'll cover everything from common infections to life-threatening failures, and of course the procedures used to treat them. All right, so here's our game plan. We'll kick things off with the basics, then get into the nitty-gritty of infections and chronic conditions. After that, we'll tackle the really critical rules around respiratory failure, and we'll wrap up with procedures that you see all the time. Okay, first things first, we've got to lay the groundwork. You see, to get this chapter right, you have to understand the system itself. Precision here is it's absolutely crucial for telling the complete patient story. And really, it all kicks off with the anatomy. I mean, from the nasal cavity all the way down into the bronchi and the lungs, every single part plays a role, and each one has its own potential set of codes. Now, with that foundation in place, let's build on it by looking at two of the most common acute infections you'll run into, pneumonia and influenza. And let me tell you, just because they're common doesn't mean that coding is simple. Here's the thing you absolutely have to remember about pneumonia. It's rarely just one code. The guidelines demand that we connect the condition to whatever caused it. Was it bacterial? Was it viral? The documentation has to give us that clue so we can lock in the most specific code. Let's get super specific with a really high-stakes example, ventilator-associated pneumonia, or VAPE. This isn't just your standard pneumonia. This is a complication of care. So you start with that specific VAPE code, J95.851, but you can't stop there. You've also got to add a code for the type of pneumonia and another for the organism if it's known. And this last point is a big one. You can only use that code if the provider explicitly documents VAPE. And that same idea, that specificity is king, carries right over to influenza. You can't just slap a code on for the flu. The codes are broken down into three totally separate categories based on the virus. J09, that's for novel flu, like avian or swine flu. J10 is for other known flu strains. And J11 is what you use when you know it's the flu, but the specific virus isn't identified. You absolutely cannot mix these up. Okay, let's switch gears a bit. We're moving from those acute infections to chronic conditions. With diseases like COPD and asthma, the codes have to capture not just the long-term status, but also any of those sudden flare-ups. Think of COPD as this big umbrella term. It can cover things like chronic bronchitis or emphysema. So for coders, the key is to hunt for documentation that gets more specific. What kind of COPD is it? And importantly, are they having an acute exacerbation? A sudden worsening of their symptoms. And if you thought that was detailed, asthma coding takes it to a whole new level. The base code is just the start. You need a fourth character for the severity. Is it mild, moderate, or severe? And then a critical fifth character to show if the patient is having a flare-up or if they're in status asthmaticus, which is a whole other level of emergency. And that brings us to this term, status asthmaticus. You really need to pay attention when you see this, because it's not just a bad asthma attack. It means the patient's attack is so severe, it's not responding to the usual treatments. When you see this code, you know it's a true medical emergency. All right, this next part is maybe one of the most critical and tricky parts of this whole chapter, respiratory failure. Because here, it's not just about picking the right code. The order you put the codes in can completely change the story of why that patient is in the hospital. So what is respiratory failure? Well, it's exactly what it sounds like, a life-threatening situation where the lungs just can't do their job anymore. We code it under J96.0 for acute, J96.2 for acute on chronic, or J96.9 if it's unspecified. But here's the absolute key. It is always caused by something else. And this quote right here from the source material, this is basically the golden rule. It says it all. You can't just code the failure in a vacuum. You have to find and code the underlying reason for it. The big question then is always, which one comes first? Okay, let's put that rule into practice. Check out this first example. You've got a patient with myasthenia gravis, and they're admitted for acute respiratory failure. So why is respiratory failure listed as the principal diagnosis here? It's because the failure itself was the main reason they needed to be in the hospital. So you think you've got it? Let's try a classic curveball. A patient comes in with both sepsis and acute respiratory failure. Both are obviously critical conditions, but which one gets sequenced first? The answer? It's sepsis. And you might be thinking, wait, why? I thought the reason for admission was key. Well, this is where a specific guideline trumps the general rule. There's an instructional note for sepsis that says you have to sequence the underlying systemic infection first. Sepsis is seen as the driver causing all the other organ problems, so it takes the lead. You see the same find the root cause logic with pulmonary edema, fluid in the lungs. You just have to ask one simple question. Is the heart causing it? If yes, it's cardiogenic, and you use a heart failure code. Or is something else causing it, like an injury? Then it's non-cardiogenic, and you're in a completely different set of codes. Okay, for our final section, we're shifting from the diagnosis to the treatment. We've talked about what's wrong. Now let's talk about how it's fixed, and specifically, how we code for mechanical ventilation. You'll see all sorts of procedures, biopsies, ablations, a tracheostomy, but the one that really has some of the most detailed and specific coding rules is mechanical ventilation, because the amount of time the patient is on the vent is baked right into the code. So here's the deal with mechanical ventilation. In the ICD-10 PCS system, the root operation is assistance, and the code you pick, it's all about time. Was it less than 24 hours, 24 to 96, or more than 96? The duration determines the code. And if you're gonna get that time right, you've got to know exactly when the stopwatch starts. The guidelines give us 3 clear starting points: the moment of intubation in the hospital, when ventilation starts to retract, or right at admission if the patient was already on a vent when they arrived. And of course, if you have a start time, you need a stop time. The clock stops at one of these key moments: when the tube is removed, when the vent is officially discontinued after weaning, or when the patient is discharged or transferred. Getting that duration right is everything. So after all that, what's the big takeaway? The codes tell a really detailed, complex story about a patient's illness. But they can only tell that story if the physician's documentation provides a clear, precise narrative to begin with. It all comes back to the documentation, doesn't it? The quality of our code is a direct reflection of the quality of the chart.